Thank you. Thank you, Sammy. Thank you for having me come and talk. I'm going to change tact a little bit and step into the medical arena, but bring it a little bit back to trauma as well. I'm going to try not to give the same as Brian's excellent talk this morning, but there will be overlap because we are doing similar things and similar thought processes. So we're going to just start basing this around a common 999 call. It's in Farringdon, about 8-minute drive on that map from Barts, which is a heart attack centre. A witness, 52-year-old male, collapsed while entering work near Farringdon. It's a witness collapse. The AD is nearby, which is not always the case, and it advises a shock. Before I kind of move on to the 2023, 2024, and then 2025 management of that case, I'm going to just show you something that we're talking about sort of cherry on the top in terms of interventions in medical cardiac arrest, but this is some of the crucial stuff that will make more of a difference, which is some of the most basic stuff. So this is a simulation that we ran at EuroELSO a few years ago, where we had someone arrest in the auditorium. You might recognize some of the actors in it. This is in real time, so the time now is when our actor calls 999, and this is the real-time response from LAS. All of this time, there's no chest compressions.
Not breathing.
Okay. What's the address of the emergency, please?
We're in the conference centre opposite Westminster.
Okay, repeat the address in full to make sure we're to the right place, please.
QE2, third floor.
Okay, thank you very much. Help is on its way to you as we speak. Listen to my instructions very carefully, please. Are you right there with the patient now?
Yeah, I'm right by the patient.
How old are they, please?
They're not breathing.
Right, is he awake?
No, he's not awake. He's not breathing.
Is he breathing at all?
No, he's not breathing. I'm medical. He's not breathing.
Help is on its way to you. Listen to my instructions very carefully. That help is being organised. Stay on the line. Okay? If there is a defibrillator available, send somebody to get it now and tell me when you have it.
Yeah, I think someone's on their way to get it now. It's on its way. It's on its way.
Right, let's see. New event. Yeah, 2286.
Listen to me very carefully. I will tell you exactly how to do chest compressions. Make sure he is flat on his back on the floor.
All right, get him on the floor. Get him on the floor. Get him on the floor.
Place your hand on the breast.
Okay, so let's just stop that there. So I find that so painful to watch. That's over a minute, and it's not the call taker's fault, but that is how the system works. That's how the automated instructions go. And that, for when we're talking about time, and time's the theme that's running through all of our talks really today, that is just time you can't get back. So if you're looking to make a change, having AEDs, defibs, and bystander immediate CPR will change more than anything that I'm going to talk to you about today. So in 2023, that gentleman gets an advanced paramedic practitioner on scene probably at about 10 minutes post-arrest to join the LAS resource. They'll have mechanical chest compressions. They'll get an ultrasound to look at the rhythm if it's PEA, see if there's cardiac activity. If they stay in VF and let's say this guy's refractory, they'll get taken in cardiac arrest to the heart attack centre. What's the probability of one of my interventional cardiology colleagues doing a PCI in arrest in this patient? It's less than a coin flip. So he's probably going to die if he has refractory VF in 2023. And then we move to 2024, and we've got an ECPR pan-London system. There are 4 heart attack centres that offer ECPR, Barts, St Thomas's, Harefield and King's. So this is the criteria. Now that APP arrives on scene, they're now empowered after 3 shocks, if they're refractory, to scoop and run with the mechanical device, and they will go straight to the HAT where there'll be an ECMO team waiting to put the patient on if they meet that criteria. When they get to the heart attack centre, there'll be a further assessment with a few kind of relative stop criteria based on the Minnesota data. How long do you think it's going to take? I showed you a map, 8-minute drive. How long do you think they're going to take to get this patient to the heart attack centre ready for the ECMO team to cannulate from the time of collapse? So we've run this system for about 9 months in London. We've had 5 patients that have come in through this pathway. 2 have gone on to ECPR, 1 has survived. Okay, because anyone that works in prehospital care will know that packaging even after 3 shocks, loading, going, unloading, getting to the hack. That's 60 minutes. And our system is geared up to have people on flow by 60 minutes. That's what the evidence supports. And also, this isn't a scalable system. This is London that has 4 ECPR centres, where actually, if you're arrested in Farringdon, it'd be fair game to try and get someone there. It's not a rural area. It's not an area where there's bigger travel distances. So it's not scalable. So 2025, and this month, we launch what we call an ECAT team, an Endovascular Cardiac Arrest Team, with a system that, if it is successful, will hopefully, very similar to the Sydney system, be something that's potentially reproducible, scalable, and equitable. So that's what I'm going to talk to you briefly about today. The whole idea of the pre-hospital thing is it's exactly the same as a heart attack centre pathway. The only difference is the advanced paramedic goes, I can't get there in time, I'll ask for the helicopter to come. Otherwise, it's the same criteria, same pathway, except obviously we don't have a lactate on scene as a relative stop criteria or a PO2, but we do have some other kind of indicators. So I know throughout the conference we've talked about ECLS ECMO with just an assumption that everyone knows how it works. I'm not going to go into detail, but effectively it's just important to remember what it is, which is a drainage pipe, normally in the femoral vein, a wheezy pump and an oxygenator, and then pressured oxygenated blood up to 5 litres a minute sometimes, depending on your cannula size, back in. And putting those cannula in are relatively simple. Switching the machine on is relatively simple. Managing someone on ECPR is not simple. If you put someone on who's asystolic, yes, you can put 5 litres of blood through a minute, but they're going to die unless you get that heart sort of contracting and decompressed quite quickly. A heart that doesn't decompress is going to clot, the patient's going to die. So actually managing after you're putting someone on ECPR can be very, very difficult. Trying to work out what flow rates, how to decompress the left ventricle, how you're going to thin the blood appropriately in order to do that. So the pipes are the easy bit, and that becomes a bit relevant later on when we talk about how you set up a system. So we know that outcomes in out-of-hospital cardiac arrest are dismal. We know that there is growing evidence of ECPR, and I'm not going to race through all of it. The interesting thing for me about ECPR is survivors with intact brains that shouldn't by right have intact brains, and I'll explain that comment in a second. And we know that it's always dangerous when there's one market leader that's so far out ahead, but Minnesota is that market leader, and it's kind of benchmarking standards that we're all trying to aspire to. Taking refractory out-of-hospital cardiac arrest, probably conventionally managed, less than 1% go home with intact brain. So when they're talking about 45%, and all of those patients have had 50 minutes of CPR, I mean, you've got to take notice of those numbers. So again, I'm not going to go through all this, but in-hospital ECPR, loads of evidence for years. Out of hospital was dismal when you tried ECPR. It was kind of no better than if you didn't do it at all. Why? Time. And in fact, when you look at the RCTs, the clear winner is time to get on. Familiarity, small teams, highly trained, and you start to see the benefits. And it all fits into this paper, which had nothing to do with ECMO, except they looked at 11,000 patients with out-of-hospital cardiac arrest. And actually, the take-home message, which I think is really powerful, is in 11,000 patients that had a North American healthcare system resuscitation, no one went home with a brain with more than 47 minutes of CPR. And that's the interesting signal in ECPR, because in all of those papers where there's really good survival, in Minnesota, where there's 45% people going home, they all had more than 47 minutes of CPR. So they should have irreversible hypoxic brain injury, but they're going home with very good modified Rankin scores and neurologically intact. That's the interesting thing about ECPR, I think. Is there something that mitigates hypoxic brain damage? Is there something about the post-ROS care that's different? Is there something about blood flow on a mitochondrial level? That's where I think the interesting evidence would be. The only thing that you can say for sure is the quicker you go on, the better. If you look after patients on ECPR, if they've had 25, 30 minutes of CPR and they go on to ECPR, they're a dream to look after. They're normally off ECMO in 2 or 3 days, and they almost always do very well. If they've been on 50 minutes, they're a nightmare to look look after. You spend 48 hours battling to try and keep them alive, keep flow, keep their heart ejecting, and then if you get them through that, a high proportion will have irreversible damage. It is all about time. So we looked in London about trying to reduce that time. We realised you can't scoop and run. You're never going to win the time battle in London, scooping and running and bringing them to heart attack centres. So we brought the team to the patient. We targeted 30 minutes to get a team there and the patient on ECMO. We threw resources, 2 ECMO consultants, a HEMS consultant, a paramedic. And the closest we got was 37 minutes. But to be fair, the patient rosked, so everyone was twiddling their thumbs for about 4 or 5 minutes. I think if it was now, we would have just cracked on even with the rosk. But so we didn't do it in 30 minutes with what we thought was an optimized sort of a model. But we learned a huge amount. What we did demonstrate is that we could do it safely and without any incidents in the pre-hospital domain, putting patients onto ECMO. And that's what we've taken forward to put into our new model, because clearly the sub-30 model can't be a reproducible model. You can't have 2 ECMO consultants sitting in a car drinking coffee all day to go to 2 cardiac arrests, both of which are unlikely to be ECPR candidates. The other thing we learned about a very resource-heavy study was that a lot of the arrests that we went to, if they're not for ECPR, you've got 4 kind of highly trained, highly skilled people not doing anything. Because actually our LAS colleagues and our advanced paramedic practitioners are more than capable of running a cardiac arrest, much better than us. So we were just twiddling thumbs, kind of like slinking into the background. And that was 9 out of 10 arrests we went to. So it's not a model that works. So then you look around at other different models, and obviously the Dutch model is kudos to them for having the first national pre-hospital ECPR system. And then Sydney, we've worked, collaborated with, and have it's really interesting listening to Brian talk, because we both models have arrived at pretty much the same conclusions. We're running very similar models, and that's just through that iterative training phase and through our experience. One model's not right; it's the right model for your system. Okay, the Dutch model works in the Netherlands. For us, it wouldn't work in the UK. However, the Sydney model is very, very more closely aligned to one that does work for us when we're basically looking for a rapid response within the M25. And we're not calling it an ECMO team, we're calling it an endovascular cardiac arrest team, because based on some of the experience Sydney have had, as well as others, we're learning that we need to do something for the 9 out of 10 arrests that aren't going to be ECMO, because actually that's 90% of workable arrests. That's where we need to improve ROSC rates. What can we do that our advanced paramedics can't do to bring added value? And I'll come to that in a second. So we've been training, initially we were just going to train a HEMS team to do ECPR, HEMS consultant and HEMS paramedic. Perfusionists train the paramedics to run the CardioHelp and the ultrasound, and we train HEMS consultants that do Roboa, are used to endovascular techniques, easy to train someone to cannulate, no problem, right? And then as soon as we started simming, because that's the reproducible model, our HEMS team's already there, just give them the ECPR stuff, it became quite clear that that wasn't going to work, even for our experienced small cohort that were used to trying to do Roboa and exsanguinating broken pelvises. It wasn't the technical skills, it was all the extra stuff that comes with ECMO, and the thing that becomes intuitive if you're an ECMO consultant in terms of connections and joins and problem shooting. So we changed our model very quickly to add in a third person, an ECMO consultant, as a proctor. Not as a cannulator, as a proctor. And why as a proctor? Well, if you get all the ECMO people in a room and say, what do you need to do to become competent at ECPR and cannulating people in the pre-hospital environment? Universally, you'll get, they need to have done 10 VA cannulations, they need to have done 5 real ECPRs on people in hospital, they need to have worked on an ECMO unit. They'll say all of that because that's what they do and that's what their competencies are. At Barts, we do maybe 12 to 15 ECPRs a year, and there's 8-9 cannulators on our rota. So in an average year, you'll get 1 cannulation as a signed-off ECMO consultant. So how on earth do you train ECMO HEMS consultants to do ECPR when you yourself are doing 1 in a year? Okay, it's nonsensical to be able to get people up to that level of an ECMO consultant and then maintain those competencies. That's what we discovered. I think that's what Sydney discovered. So can you do it just on simulation? Well, possibly, but there are risks and severe risks of complications with that. And it depends how willing your system is to accept VV by accident, AA by accident, cannulas falling out, kinks, clots. How willing is your system, and most importantly, your ECMO centres that are people going to be looking after these patients, whom in the best case scenario, 6 out of 10 are going to die, and the moral harm you're going to give to the units, how happy are they going to be to receive ischemic legs and complications? And so that's why we designed the proctor model, whereby we train on the job. Just as you would in the hospital. If you come to me to learn to cannulate, you'll cannulate, but I'll be standing there next to you. I'll be making sure you're happy with the wires. I can feel the wire if you want me to give you reassurance. I can help if the cannula doesn't go in. It's a proctor model from someone that's very experienced. It doesn't replace the simulation, the task training, the fact that all of our consultants will know how to cannulate with their eyes closed. It's just in that real world, when things don't go right, having that experienced proctor. As people gain competencies over time, then that's fine. We can actually sub out that proctor role. In can come someone else training. But that's the only way we felt you're ever going to get that HEMS team up to a level of confidence and competency quickly. So there's a heart. It's not beating. So in comes a mechanical compression cusp in a second. This is very similar to some of the stuff Brian was showing this morning. Okay, and what you can see there is the cusp is compressing the right ventricle. And if anything, it's obstructing the left ventricular outflow tract, and there's smoke in the LV. Okay, so that's a classic thing that Brian described this morning, where there's going to be a reasonable end-tidal CO2 because you're moving blood out the right ventricle, but there's no coronary perfusion. You're not going to get ROSC. The brain is going to be in big trouble. And hearing anecdotal reports from Natalie, from other people who have been putting TOEs and arterial lines in arrests, it is clear that we often think we are fine with our mechanical compressions, and we're not. Okay, and in fact, when you have a resuscitation ITU, the first thing you do is look at the art line trace, right? And then you say, no, move to the left, push harder, push faster, and you watch the diastolic go up, and then you know you're going to get ROSC. In the pre-hospital environment, we don't quickly have that. We've got end-tidal CO2, which is flawed. Trying to feel pulse is going to be very, very tricky and subjective. So that's why we've kind of called it an ECAT team, because we want to bring in those measures to optimize that ROSC. So we want to be putting TOEs in the pre-hospital environment and designing a training package for that to identify, very similar to Sydney, where just moving the cusp an inch to the right suddenly changes everything. But before you saw that on TOE, you would have no idea that you were not giving effective compressions, because the placement of cusps is doing the most for the most, but it's not individualized. Okay, and we're going to put femoral lines, 4 Frenches in everyone straight away, if they're not for ECPR, so that we've got that diastolic target pressure to try and get ROSC. And we're going to unleash Robbie and his balloons on the ones we get to quickly that aren't for ECPR and do medical rebirth, because again, it's about the only thing we know is get your coronary perfusion pressure up and you'll get ROSC. It's the only thing we know that's got fantastic evidence. And we know that that is very good at getting your diastolic pressure up. And the great thing about medical rebirth is it doesn't have to stay up very long. So you just need to get that diastolic pressure and get that ROSC. So the team's going to do other stuff. I'm just going to whiz you through. Hopefully this sounds off because it's got cheesy music. But I'm just going to whiz you through for 3 minutes and then 5 minutes to bring it back to trauma at the end. I'm just going to talk you through our workflow so you can kind of envisage how it works in a cardiac arrest. So it's a 3-person role. Sean is playing a paramedic here. And then you've got a proctor, me in the proctor role. And then you've got Jay, who's going to be the HEMS consultant, cannulating. And everything, just like Sydney, like Brian showed, is rehearsed. It's been rehearsed to death as to where everything is, where you put everything down. Although you've still got to be a bit pragmatic, because as you know, in pre-hospital care, patients don't just collapse in a nice 360 ground floor area. You have to adapt to your surroundings. And so there has to be a little bit of pragmatism in it. It doesn't mean that you can't have a Formula One approach at the beginning, as long as you're able to kind of bend as things happen. The order of which everything is opened and put out, the order of which people get scrubbed at different times, the crucial instructions to the top end to try and get ROSC. ROSC is better than anything else. Ultrasound, 2 ultrasounds. We put sheaths in. We don't go straight to wire. We always put sheaths in, because this is it. This is the key. It's the key for Ebola. It's the key for ECMO, is the vascular access. Once you get that sheath in, that's your ticket. That's your golden ticket. Okay, you can then change wires. You can do all kinds of things. The sheath brings everything with that. We check positions on either double barrel or IVC view to make sure we see a wire in the IVC. We don't worry about arterial wire as long as we don't see 2 wires in the IVC when we're putting the arterial wire in. We have the same criteria. We have a stop, which we'd only do after 3 shocks, but the chances of us being ready to go on within 3 shocks is negligible to nil, so that's not a problem. We make sure that the resuscitation continues, but we stop giving adrenaline and we stop giving shocks at the point that we're course committed. The cannules, we go for bigger size than some services. The evidence isn't there one way or the other, but intuitively, our feeling is more flow in the immediate post-ROSC period is a good thing. So we go for kind of 25 and 17, which is a bigger setup than some. That will give you 5 litres of blood flow in most people. The cardio help is sort of the competency trained by perfusion. So every one of the team has passed an assessment that a perfusionist would have to take for managing the cardio help. It's not trying to replace perfusionists. You can't. It's a whole specialty. But cardio help management is a tiny bit of what a perfusionist job is. And actually, you can train someone to manage a cardio help. Especially if you've got the expertise of perfusionists doing it. And again, we talk about buy-in in systems. Any system needs buy-in from the wider group, from the ECMO centres, from the perfusionists. It's absolutely crucial. And then we go to a femoral arterial line straight afterwards, so we can keep the map up. And then actually you've got all the time in the world to package and take the patient in for their PCI. Take all the time in the world. It can be controlled from this phase. There is even some evidence that the period of reperfusion is not a bad thing before they have their PCI. And yes, they all need a PCI because if you look at the literature, over 95% of these people have a culprit lesion as the cause of their arrest if we've identified them. Right, last 5 minutes because I know we're heading into overtime. I'm just going to kind of link this back because training a team and giving a team the capability for ECMO and ECLS opens the door potentially to other stuff, such as trauma. So here's another case, teenager hit by a car. It was a secondary transfer. They'd accidentally gone to a trauma unit, which is the curse of the trauma system. It's great if you get to the major trauma centre, but it de-skills the rest of the kind of satellite units for big major trauma. So it can cause a problem if they're driven by a mate and dropped off at the wrong hospital. They were moved by a HEMS unit that's intubated the patient and brought them over. TBI, but with a high GCS. It's with a traumatic subaortic and subdural, but none of which needs neurosurgical intervention. It's for Bolton monitoring. Flail chest, contusions, a huge left hemothorax, a large amount of blood, 2 VF arrests on arrival at the major trauma centre. And the team have done a resuscitative thoracotomy and clamped the left lower lobe to control the bleeding. And then the call goes out, would you send an ECMO team and put this patient on ECMO? There's a biventricular failure on a TTE. That's the pH, that's the lactate, is on 0.2 of adrenaline, systolic of 70. So if I ask this room, everyone will say yes, put them on ECMO. But if I ask an ECMO room, everyone will say no, because this would be well outside the realms of comfort zone for most ECMO centres. That's not a pH in ECMO land that we see survivors. Okay, we don't do trauma all the time. And with this history of bleeding from a left lower lobe that's clamped, arrest, blood in the brain, someone you're going to put on ECMO, is going to be no. So Zane talked about how people die in trauma, and what we have a suspicion of is that there are patients that come in that have bled, that are saved with their damage control surgery, their resuscitation. They're given 8 million units of blood. Their right ventricle, which is a bit rubbish, gets overinflated with all that transfusion. They go into right ventricular failure, they have myocardial stunning from low perfusion, they have reperfusion hits, so overall both ventricles are pretty ropey. They go to ITU and then they start to just escalate on their vasopressors, and someone calls it sepsis at 24 hours, and then they die of multi-organ failure at day 3, 5, 6, 7. Okay, it's a familiar story, everyone's seen these patients. Okay, you have to prove that cardiogenic shock is the cause. You can't just say it's cardiogenic shock, it was never sepsis. And that's kind of what we want to do, because we think that there's potentially a cohort of patients that would benefit from VA ECMO, especially as you don't have to run them on heparin now. So we've kind of got a charity-funded project at the Royal London, which has allowed us to sort of train a non-cardiac centre to start putting in PA catheters so we can get some numbers and work out what the index is and whether they genuinely are in cardiogenic shock. We have an MDT trauma shock call, which we've learned a huge amount, and for instance, don't put out a trauma shock call in the heat of battle when a patient just arrives at the major trauma centre, because the ECMO team want to know the pH and the lactate and every single bit of detail, and the trauma surgeon doesn't want to tell them that because the trauma surgeon is trying to save their life, as is the trauma team leader, and it just doesn't work. So actually what you've got to do is get an ECMO consultant to the patient, and by that time then you've got the trajectory, the information, and then the call can go out and it can be a proper MDT discussion. So, we have posters trying to flag patients that we think are ones that should be put out for trauma calls, for discussions, and you won't be surprised that the ones we're looking at are the ones that we think will be low flow states and myocardial failure because of lack of perfusion or reperfusion injuries. And I'm just going to finish on the first 4 that we did. It's not enough to take significant learning away, but it's been very useful for us from an ECMO perspective. It doesn't do trauma as an ECMO team, because there are 2 patients we would never have previously put on without this project, both of whom would have died without ECMO. The one that I kind of told you about at the beginning, who was actually turned out to be 14 years old, and actually went on to a very long ECMO run, ended up with an RVAD. His right heart absolutely went down, this poor kid, through hypoxia, through overtransfusion, through all the things that I said, and yet he's back at school. Absolutely would have died without it. And then another chap that was run over and actually had a ruptured tricuspid valve from the car going over his chest, ended up having the tricuspid repair on ECMO, and again is back at work. So 2 great success stories. Interestingly, 2 sad cases that didn't survive, both of which were penetrating, both of which were post-thoracotomy ROSCs, both of which I don't think the heart was beating when the HEMS team got into the chest, and I think that's probably the key thing. And you pair that with their lactates, and that's probably why they just died of just total body failure. I think they were dead, and then they were resuscitated at a point that they were beyond salvage. But again, only 4 cases in, lots to learn, but it starts to help us focus on that case selection and brings it back to where we're going to be in 5 years' time, in 10 years' time, when we have potentially a HEMS team within a service that have the capability to deliver all of those endovascular tools, including ECMO. And who do we pick? Who do we deploy? Who do we send a team to scene because we think they might need mechanical support? Who do we put in the back of an ambulance and go as fast as we possibly can to resus, and who do we deploy the robot on? And those are, I think, the questions that we're asking ourselves, with the theme running through of it being basically time.